7-year-old Aman is spending his afternoon running through the rural scrub vegetation near his home, completely unaware of the environment he has just stepped into. Hiding in that same brush is a microscopic predator, a larval trombiculate mite, better known as a chigger, waiting for a host. When Aman brushes past the grass, the chigger latches onto a skin. It finds a warm, hidden crease and bites. But the bite doesn't sting, it doesn't itch, and it leaves absolutely no immediate mark. Aman feels nothing. That invisible, painless encounter has introduced a lethal pathogen into his system. Inside his body, the infection is already beginning its first cycle of replication, long before a single symptom appears. Within a few days, the pathogen takes hold. Aman develops a sudden, severe fever of 104 degrees, accompanied by violent chills and deep muscle pain. To a local clinic, these symptoms look entirely routine. They mimic seasonal viral fevers, malaria, or dengue. There are no obvious signs to distinguish this illness from a dozen other common tropical diseases. Doctors administer standard fever reducers like paracetamol, but his temperature refuses to drop. By day 5, his condition deteriorates rapidly. He becomes highly confused, struggles to breathe, and then begins vomiting. Standard blood tests for common infections come back completely negative. Aman is crashing into multiple organ failure, and his physicians are forced into a medical vacuum, fighting an enemy they cannot identify. Aman is rushed into an intensive care unit in critical condition, requiring immediate respiratory support to stay alive. Realizing that standard lab tests are failing them, the ICU physicians change tactics. They step away from the monitors and perform a meticulous, inch-by-inch physical examination of his skin, searching for any hidden physical evidence. Tucked into the skin fold of his armpit, they find it, an Eschar. This is a painless, black, necrotic scab surrounded by a red halo, the physical signature of the exact site where a chigger bit him 10 days ago. Finding that single physical mark rules out dengue and malaria immediately. It shifts the diagnosis from a generic viral illness to a highly specific bacterial assassin. This electron micrograph shows that specific pathogen. It is an intracellular bacterium known as Orientia Tsutsugamushi. This diagram shows a cross-section of a healthy blood vessel. The bacterium targets the endothelial cells that line the vessel. Once inside, it begins to multiply. This localized invasion triggers a condition called microvasculitis. As the bacteria reproduce, the infected blood vessel walls become violently inflamed. They begin to degrade and tear apart, causing the circulatory system to leak fluid into the surrounding tissues. When these microscopic leaks happen inside the lungs, fluid pours into the surrounding tissue, flooding the air sacs. This triggers acute respiratory distress syndrome, effectively drowning the patient from the inside out. The exact same process occurs in the brain. Leaking vessels cause severe swelling and inflammation, known as meningoencephalitis, which explains Aman's sudden confusion and rapid neurological decline. His failing organs are not reacting to a generalized infection. They are shutting down because his entire circulatory system is being systematically dismantled. We now know why the initial treatments failed. Orientia Tsutsugamushi lacks the typical cell wall found in most bacteria, making it completely immune to common broad-spectrum antibiotics. But by identifying the Eschar, doctors can deploy a targeted therapy. A specific antibiotic called doxycycline attacks the bacteria's internal machinery. Within 48 hours of the first dose, the fever breaks and the patient stabilizes. This map highlights the massive geographic zone of the Tsutsugamushi Triangle. It spans from Japan down to northern Australia and all the way across to Pakistan and India. Over 1 billion people live within this zone. They are exposed to a highly curable disease that still claims lives simply because it so often goes undiagnosed. Outbreaks spike during wet seasons in rural areas. When the rains arrive, chigger populations explode in the low-lying scrub vegetation surrounding farms and villages. Because the bacteria possess such high antigenic diversity, researchers have struggled to create an effective immunization. Today, there is no viable vaccine for scrub typhus. For populations in endemic areas, protection relies entirely on environmental defense, utilizing vector control, wearing protective clothing, and consistently applying insect repellents. Scrub typhus is a deadly but completely curable disease, relying on diagnostic blind spots to kill. Survival demands a medical community that refuses to accept a persistent fever at face value and always knows to hunt for the hidden black mark.